deformity will you follow in these scenarios? Start from the right side. We'll go one by one.
So using robotics, we usually follow a functional alignment philosophy with a kinematic start point.
Okay.
In a conventional case, I would do mechanical alignment.
Okay. So then you can take the next question. If it's mechanical or whatever, so what all modification will you make for this recurvatum deformity? We'll more focus on this recurvatum deformity.
As all of us know, in hyperextension, there will be tight flexion and there will be increased extension gap. So all our strategies should work on increasing the flexion gap, decreasing the extension gap. So I would cut the DFC very less, like around 5 to 7 mm to start with, and cut the PTC also very less. But I will increase the slope. I will downsize the femur so that I get more flexion to accommodate the additional extension. And also I will keep a backup of TC3 semi-constant as a backup if I am not able to match the extension flexion gap.
One point about this slope. Do you recommend the more slope or less slope? Because when you give more slope, actually the posterior capsule becomes lax, then you will go more into hyperextension. Or will you reduce the slope?
The slope is standard, but I will not err at like lower slope. It will be like on the more side, not on the less side. Yeah.
More we'll say we'll reduce the distal femoral cut. Is there any criteria that how much amount of distal femur will reduce?
Yeah, Spurs criteria, what we have is more than 10 degree, we cut around 8 mm. So more than 20 degree, you cut around 7 mm, 5 to 7 mm. Depending upon it, not only depend upon the how much laxity, how much is the hyperextension, it also depends upon the laxity of the tissues. If it is highly lax, like other joints are also very lax, so I will cut very less, like 5 mm. So this we will keep doing since so many years, but with robot now we can do the same thing, like we reduce the DFC, we take the PTC up, and in the functional element, the same philosophy can be applied in conventional as well.
Fine, good. So let's see, this is how we went with the robotics. You can see as the proximal tibial cut has been reduced to 5.5, just reduced because just touching the medial side, and just a functional alignment, 1 degree valgus and 3 degree varus as depending upon the MPT and LDFA is being recreated. And then comes this, most importantly, your hyperextensions. You can see around 18 degree of hyperextension. So what the dictum is, if you distalize 1 millimeter, will correct 5 degree of hyperextension. That means once you balance your coronal deformity, then you go to the sagittal plane. That is the 9 mm distal femur become 5.5. Okay. And so this is the final, and how the deformity is being again exactly what is being replicated, and this is what the patient is walking at 2 months down the line. Okay. So we'll go to the second case. It's a 64-year-old female. There's no comorbidities. BMI is 37, and start from the left. What's your choice of implant, or how will you proceed?
Yeah, so 64-year-old, severe varus. So the choice of implant will be actually posterior stabilized knee, and though it looks severe varus, and I think it must be around 20 to 30 degree varus, so I think though it looks quite stiff and it's quite severe, intraoperatively when you go, and most importantly when you remove all the osteophytes, you get good amount of, it will be helping in your balancing. The other point is, you said a BMI of 37, and especially in my hands, anyone above the age of 35, it is always better that you put a short stubby stem in the tibia. And so PS implant, conventional total knee with a short stubby stem for both sides.
Anything to add, anybody? Anyone, anything to add?
There is a medial defect on the tibial side.
Yeah.
We have to reconstruct it.
So
we have to check the size of the defect and plan accordingly. If the size of the defect is less than 1 centimeter, we can go with cement and screw technique. If it is beyond 2 centimeters, then we have to use wedge and augment with the stem.
Fine. So this is what I did in 12 years back, but after 18 months, the right side started to fade. So that's why the older days the short stubby stem was available, not available. So we just, because it's failed, we revised it to a stem. So the take-home message is, if the bone quality is poor, there is a defect. If you want to build up, or the BMI is high, you have to put a stem. Preferably nowadays, it will be a short, stubby, cemented stem. Am I right?
Yeah, and just one more thing, just like this, the case which was just done by Sir, you will have like a backup hinge and LCCK for these kind of cases. Otherwise, you need some options for bailout.
Yeah, that's it.
So just one point to add with that. So there is, compared to other things, there's no randomized control study to find the effect of stems, short stubby stems. So the only data which we have is the Australian registry. So those patients, BMI above 40, when they've used conventional PS knees, they've shown that at the age of 10 years, there is a 17% failure rate at the tibia across all systems, whether it's a Zimmer, whether it's a DePuy. So the recommendation they give, or recently in the CORR, last year there was an article which said that if you have a BMI more than 35, consider using a short stem on the tibial side especially.
And also the size of the tibia also matters.
Yes.
Yeah, we use stems very low threshold in our institute for the last 20 years. And we don't have any guidelines initially. We used to put long stems depending on the availability. And now, 20 years down the line, we have not seen any gross negative sides of these stems at all. In fact, a lot of rheumatoid knees just survived because of the stems. Otherwise, they would have sunk. So definitely, rodding is on the tibial side, has got a very valid role in osteoporotic bones, in high obesity people. But short and stubby definitely are good. But long, with an impression that they will give a tibial shin pain is ill-founded. We have not found anything. Of course, we are now writing a paper. In fact, Ratnakar is doing a paper. We have done almost 300 plus knees, 500 plus with the tibial stems. We are coming up with a paper. The long stems are also not having any problems. Yeah.
One more thing you just want to know for these patients is whichever knee you're going to use should have a stem option, because you don't want to be kind of caught out. And if you have like a female patient, very short tibia, 1, 2, lot of them don't have a stem option in that. So then you need to have a proper system which will give you stem options everywhere.
The tibial surface area matters a lot. If the tibial small size, you have to use a stem. So a 76-year-old male, it's a case of a neuropathic joint. So just case, you do have any contraindication for a TKR while performing a TKR in a neuropathic joints? Anyone can take it?
For a neuropathic joint, I wouldn't say TKR is absolute contraindication, but at the same time, the patient should be counseled that the pain may be able to come down, but implant survivorship should definitely be counseled.
Yeah, any neuropathic joint associated with active infection is definitely a contraindication. A neuropathic joint associated with neuromuscular issues, like if they don't have cordyceps power properly, like if they have 3, 4, also is a relative contraindication in our books. And only thing, neuropathic joint, the cause of the neuropathy has to be found out by a proper workup involving other specialists.
What difference does it make?
Sir, if it is like a secondary to diabetes, we have to control the diabetes to create prevent the further complication. If it is secondary to spine, we have to address the spine so that the concurrent issues will not happen, sir. Like the worst thing of the...
You know that anyway. What I'm saying, the endpoint doesn't make any difference as far as your etiology is concerned.
Yes, sir.
You will control diabetes, you will do the spine anyway.
Yes, sir. The neuropathic joint, usually the damage is due to the less sensation in the original joint. Similarly, the same injuries will also happen in the artificial joint, and the survivability may come down. That's what in one of the papers.
Survival, we all know that, but you can put a joint in polio also.
Yeah.
You are saying contraindication?
No,
neuromuscular?
Neuromuscular polio is not for functional, sir. It's only for the pain relief, sir.
Yeah, that's what I say. Again, a very important point for the youngsters is how do you communicate with the patients? That is the half of the battle won. When a polio patient comes to me, or even Parkinson's comes to me, I would say there are 2 advantages of knee replacement. The one is pain relief, second is improvement of gait. But in your case, I can't promise the second side. Only relief of pain is promised. That is how you should communicate, and then half battle is won. Yeah, go ahead.
Yeah, perfect. If it's all doing, what implant is your choice? Will you always go for a constraint?
I always go for constraint. No compromise in that.
So this is the post-operative X-rays, and this is how the this is how the patient is walking at 2.5 months. So actually, the patients came to me and told me that if I could have stand up, then I would have committed suicide. That I was so bedridden at that time. So the patient, if counsel, as the Guruvar Reddy sir told, the counseling the patient is something very important. You understand what is the demand from the patients. Okay.
So recently, just to add on that,
Yeah, sure.
recently in the JOA there was one paper on neuropathic joints, and as we know the 10-year survival is significantly less, it's about 30% less. But one point in their study, one of the factors they found in neuropathic joints, if your quadriceps power is more than 4+, they say they have a better outcome overall. So that is, I think, a very important
So 4
point.
plus is almost like a normal joint.
Yes, sir, that's what, so that if those people who have 2 or 3, their outcomes are poorer. So that's one factor.
And it's a 70-year-old female. She has deformity with both knees for more than 20 years. And this is how we are more focused on the right side. So 45-degree of valgus. It's completely correctable. It's a valgus thrust gauge. Range is reasonably good. And this is how the patient's gait is. And this is going to be the X-ray. So the question is, what's your implant preference, and can you consider MCL advancement, or for especially in Indian scenarios, if there's a foreign, no doubt at all, we have to go for a constraint. So can you consider MCL advancement in this type of cases? Or you do, because it is a deformity is completely correctable. That means the lateral side is normal.
Yeah, I prefer cruciate retaining implant in this case. Actually, that is a medial, very good medial constraint. We can correct the lateral deformity, that means lateral contracture, by inverted cruciform release. If still it is not functioning, then I will go with hinge.
Fine. Any options?
I think we have to keep all options with us on table, and you start off with that and then keep going. Even the medial osteotomy also can be one of the techniques, the MCL.
Yeah. This is a medial parapletal approach. We have done a significant release of the ITB from the Gary's tubercle. And this is thing I think you can see after the trial implant, you can see in full extension, if you give valgus force, whereas lateral side is stabilized, you can see the opening. But once you flex the knee to 90 degree, you can see even it's fully forced, it gets stabilized. So this is the things I think about why I can't do an MCL advancements. This I do an medial epicondylar osteotomy and just pull it proximally because the flexion is okay. The extension is lax, you fix it. And this is the immediate post-operative X-ray. And this 2 weeks when the patient came for the suture removal, how she is walking. And this is at 2 months down the line.
Samir, it's a good technique. I think I have not done before.
Yeah.
We'll just take the faculty with the permission of the right, Rajkumar. Any medial advancement?
No, I will not actually do this.
Have you done it before?
No, I don't do this. Without doing that, I will be able to manage with the PS knee. I will do a PS knee.
Okay.
I'll be.
You mean to say that there is no need to do this one?
It all on table. If he feels that if it advances, definitely he is able to manage it, balance it little easily, rather than doing
Yeah, for me it looks like a straightforward, like a valgus osteotomy.
It can be considered. Yeah,
like
definitely.
a valgus epicondylar.
But
Sharon, yeah.
No, this is technically I don't think there's a challenge in this, but the problem is whether MCL is attenuated, it's stretched out, and that one you're advancing, will it maintain its stability is my little concern, because it's elongated. Now you're advancing it, but how strong is MCL is my worry.
So whether we work on the tighter side or the looser side?
See, if you look at the standing X-ray, standing scanogram here, it is lengthened, medial side is stretched out to the point of almost being incompetent. And the proximal migration that you did with MCL is almost more than a centimeter.
Yeah.
Now, more than a centimeter proximal migration, what is actually the kinematics of that knee with respect to the medial collateral ligament? That is something that one needs to think of. Because 1 centimeter proximal migration is a serious migration for the medial collateral ligament.
And also we need a stress view here to actually got. So stress views. Do you have a stress view?
It's a weight bearing full length.
No, stress view. Stress view.
This particular procedure is popular in Kerala. I've seen a lot of surgeons do it. We like to see long-term follow-up, but elsewhere people don't do it because of the reasons that you're changing the MCL attachment, and then your joint line becomes completely off.
This is more of a coronal plane.
In contrast to the lateral epicondylar osteotomy, where the LCL is not the only structure, whereas the entire thing is on the MCL on the medial side. The lateral side, epicondylar osteotomy works well because there are a lot of other structures as well, and LCL is one of the structures. So we are okay with that, but not with the MCL is the only structure on which the entire biomechanics is hinging on.
It also puts a stress on the mid-flexion stability in this.
And 1 centimeter migration in flexion, imagine what is happening to that 1 centimeter proximal migration in 90 degrees flexion.
That's what I said.
Where is that medial collateral going?
In the flexion.
Significantly.
Center of rotation is getting shifted.
Second thing, even the bone is so osteoporotic. You make an osteotomy, shift it proximal, put 2 screws, it just crumbles. I do not know whether it will really remain long and it is stable in that situation.
So this is around 2 months, 2.5 months post-op.
See, we,
Right, okay.
Yeah.
we have done a few, in fact 3 middle epicondylar osteotomy, shifted the MCL proximally and fixed it similarly, same indication, valgus knee. It works, but you need to do two important things. That you should not touch the MCL, there should be no release of the MCL, just the epicondylar osteotomy and a thick enough segment of the bone. And it should be reasonably fixed up well. We have 1 patient follow-up, we have 12-year follow-up of the same.
This much amount of thickness bone should be there,
It's
otherwise
very
it will fly away.
Right, I think the jury is
desperate measure.
Significant amount of jury is not with you.
Yeah.
So have you got long-term results?
So almost 1 year.
1 year.
1 year, yeah. 74-year lady.
Right, something new to ponder.
So this 57-year-old male had a lateral crossing wedge high tibial osteotomy around 13 years back. Again, he's a high BMI patient. We are talking about the left knee is a 30-degree valgus. It's not correctable. There's a fixed flexion deformity of 15 degree and the range is up to 100 degree. So we are more focusing on the left side. So what are the anticipated problems in this case?
Yeah, there are 3 major anticipated problems. One is it has deformity both in sagittal and coronal plane, which are fixed. So especially valgus with FFD, when you correct, there will be chance of neurovascular deficits that you have to add on. And second is there is a rotational element also in this because of the high tibial osteotomy, the previous high tibial osteotomy. So that also has to be taken into account. And third thing is while we correct the deformity, we may not be able to balance the flexion and extension of the primary implants. We have to keep a TC3 as a backup.
It's a low tibial osteotomy. It's not a high tibial osteotomy.
And 2 more points actually. One thing is the patella baja actually. The patella baja, this one will be very difficult in exposure. And second thing is also the lateral tibia, the bone loss. I think those 2 things. But patella baja is a significant thing which during surgery especially, it's going to be very tight and your exposure, you have to be aware of that.
So will you prefer to have some technologies like robotics in this case or just conventionally manage? Or will you feel any extra advantage with the technology?
Yeah, robotic will definitely give additional advantage in calculating the rotational issues and also the flexion extension gaps management.
So these are some of the anticipated problems we already discussed. The deformity which is not correctable, the tibial metaphyseal bone loss due to the lateral crossing wedge osteotomy. There's a high posterior slope. There's an extra-articular proximal tibial deformity, as very well mentioned, the patella baja. So having a difficulty in patellar reversion, the posterolateral tibial plate defect, and translational and metaphyseal mismatch of the proximal tibia. That is, tibial stem can hit on the lateral cortex. So again, we went with the robotics. You can see how the stem goes in, and there are almost 10 degree of flexion deformity. So this is basically the plan. Will reduce the tibial thickness, will give a slight valgus in the femur, because to compensate this flexion deformity, slightly 1 to 1.5 mm, increase the distal femoral thickness, and we went with the posterior stabilized. And instead of that, we did a lateral epicondyle sliding osteotomy to distalize and posteriorize this tight flexion gap rather than going for a huge release. Even after the ITB pike resting and posterior capsule release, still there was a persistent lateral tightness. That's why we went with a lateral epicondyle sliding osteotomy. And this is going to the postoperative gaps and with a residual valgus of 2 degree. And this is a postoperative X-ray. You can see the sliding osteotomy screws. Yeah. Anything?
Yeah, that's what, like, in the previous case, what we discussed, like proximalization of the osteotomy.
Yeah.
So usually these osteotomies will help to open the space rather than reducing the space. So these osteotomies should be, I think, at least for our Indian scenario, should reserve for opening the gaps, like what you did now, rather than the previous case. Yeah.
Because for the completion sake, only pointed 2 cases. And so case 6. As a 46-year-old female, she had a neonatal septic arthritis. She had a slip and fall at the age of 12. She underwent some native treatment, developed stiffness, physiotherapy, and then even underwent the Ilizaro lengthening around 8 centimeter of femoral side is lengthened. So this is how the clinical picture is. And she has 5 degree cordyceps lag and just ranges up to around 30 to 40 degree. There is no recurvatum deformity. And all clinical parameters, infective parameters are normal. This is going to be her X-ray. And few more, you require CT definitely. So this is the CT scan. So what is plan? Whether we'll leave alone or just go for a fusion or can consider a replacement in this case.
What are her major symptoms?
She has pain, started to have pain, that's why.
Okay. So I forgot the age.
Now she is 48 years almost.
Okay. So if pain is there, then definitely we can think of joint replacement surgery. But we should understand this problem has happened before the skeletal maturity. So whenever any joint gets infected or any changes happen to the joint before the skeletal maturity, and we deal them after post-skeletal maturity, there will be huge contractures. It's unlike other cases. Like if they have developed severe stiffness with arthritis after their skeletal maturity, it is different because here each and every tissues are contracted, like capsule, because everything is in evolving stage. We only know about the bone, but the other tissues are also in evolving stage when they are becoming skeletally matured. So when they have a pathology before that, the entire 360 degree of the knee will be contracted in terms of capsule, muscles, ligaments, and even the bone will be, you can see there is a definitely procruatum deformity in the femur. This is due to developmental, during the skeletal, whatever changes has happened. So in this case, we should not promise that they will get 100% range. So we should promise at around 0 to 90 degree range. And we should keep a backup of constraint because you may not be able to manage with primary implants because of the tissue contractures. That's
so with this small size of femur and tibia, can you accommodate a constraint? That's a problem.
Yeah. So there are few constraints like, the link one is the smallest one, extra small, what is available is the smallest available constraint implant. So that can be accommodated, but of course we have to, with CT scan, as CT scan is already done, you calculate the medial lateral diameter, anteroposterior diameter, and check the minimum diameter should be around 57 mm in the femur. If it is not there, then it is difficult.
So this is all X-ray.
So regarding the size of the constraints, one of the constraints which is not commonly used in India, even if you have a size of 53 or 51 mm in the femur, you can use an implant cast. It's from Germany. They are most into tumor implants, but they have these special spot sizes. In Indian size, the GK is butterfly. That is a system which overall in the constraint has got a very small hinge.
Customized implant is available?
The customized implants, they do. So nowadays there are a lot of things, but off the shelf, the implant cast is the one, it goes up to even 49, size 49 mm they give.
So because this anticipated, we went with templating, otherwise usually we won't do a templating. The femur is says something around size 1 of the Smith & Nephew.
Can we go back to the preoperative X-ray, the lateral view? The biggest issue is the procurvatum of the femur.
Yeah, correct.
In these cases, the procurvatum of the femur, and the posteriorly there is a lot of outflowing of the bone. So the posterior condyle that you remove will be very huge amount.
Correct.
And most likely you will have to leave some amount of posterior condyle.
Yeah. And you can also see the patella is almost subluxating.
That can still be managed, but the procurvatum will stop you. You can use only a very small femoral stem if you have to use.
Samir, this femur is also deformed, and the medullary canal is somewhat sclerotic, and so you cannot use a conventional instrumentation. Probably you need a technology to.
You need a technology.
Technology for this part.
And also, as we mentioned, there's significant procurvatum deformity more close towards the joints. So you may not be able to put a stem in this case, femur. So definitely we have to go with the technology. So this is, once I open, this is how the joint, this is the robotic pins. And once it is the plan, this is how the post cuts, you can see. And this is the plan we did. As is mentioned, you can see around 17 to 19 millimeter of posterior condyle bone need to be removed to make it really into these shapes. And this is the final. We went with a residual varus of around 4 degree. And this is the final closure, and this is the post-operative X-ray. You can see still there is a significant amount of almost 15 millimeter of insert has been used. And this, you can see the lateral, the alignment looks okay. And the posterior condylar offset is being recreated. And even the patella has bent to the trochlea. And this is how the patient is at around 3.5 months post-op. She's got range of up to 80 degree.
How much was your distal femur cut, sir? I couldn't see it in the...
Distal femur cuts, just show you. It's around 6 millimeter and 11 millimeter.
Okay. And still you could end up with such a high poly?
Yeah. And you can use the tibia just 1 millimeter shave from the middle side.
Okay, right.
And this is, I think this is the last case, 2 more minutes remain. It's a 61-year-old male, it's a post-traumatic. He had a traumatic amputation and the reimplantation done around 2014. And this is the range of movement, 0 to 40. This is a grade 2 varus laxity. The patellofemoral joint appears to be very stiff. Pulse is good. Cortices active, he has an active cortices power. So this is a X-ray. So how will you take it forward? Do you want to do a 2-stage procedure? Just take out the implant and we'll do it later? Or?
In this case, we can manage with robotics. So just remove the distal 2 screws and retain everything and put, we can, but only thing, once again, range. We don't know how much range we get, but range cannot be promised, but we can go ahead with robotics.
And range as well as you see the femur condyle, the distal femur is internally rotated and malunited. That is the reason why the patella is being subluxated laterally and is hitting the implant. So will you, and you can also see in the coronal plane, the distal femur morphology is quite abnormal. So still we go with the robotic and a standard implant, or will you go with a more of a constrained implant?
No, backup is always constrained. If you do, if you can get away with technology and with minimal, less constrained implants like PS or CR, so that should be great. If you're not able to manage, obviously you have to remove the plate and obviously you have to stem it, bypass the cortices and all those things.
So intraoperatively there was a significant, once we get the range, we can see that the lateral structures were incompetent. So we proceeded with a Zimmer hinge knee, and this is we just removed the plate, only one screw was broken and it stayed there, but luckily my stems got it there. And postoperatively this is the range of movement what the patient got, and you can see the patella also got into the nice tracking.
Now, why not robotic in this case, and why used hinge?
Because when I opened the lateral structures were incompetent.
Oh, lateral structures. Okay,
only the range of 30 to 40 it was stable, but beyond that there is significant opening in the lateral side.
Okay.
Okay, thank you.